Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that before we get started that you can download the PDF of today's ECG down in the description below. And don't forget to like and subscribe to the channel if you enjoy these videos. So let's jump into it. So the first thing I'm going to do is look at the forest, and so I just get an idea of what's going on. And so maybe I come down here to V5 and I see I've got a narrow complex rhythm that seems to have these wide, complex, kind of crazy looking beats every third beat, right? So if we repeat that again, we get narrow, narrow, wide, and we get one more time, narrow, narrow, wide. So we've definitely got some type of pattern, and so we can maybe try to work through what is causing these patterns. We know that those wide complex beats that we said are early, these are premature beats, right? So we know there's either premature ventricular, atrial, or junctional contractions. And but before we really jump into that, we need to figure out, well, what is the behavior of our normal beats, the normal rhythm? And so maybe I just quickly scan through and look for P waves in front of my narrow complex QRSs, and I'm not sure I see any. And so let's do a little bit of a deeper dive. What is the atria doing, right? Well, I know that if these are narrow complex QRSs, that tells me that it's likely coming from the AV node and going down that His-Purkinje system that is what causes rapid depolarization through the ventricles. So ideally, you would hope that a P wave is what is causing the AV node to be passing that signal down. But like we mentioned, I'm not seeing any P waves, but it's our job to be very, observant and look through all the different leads, and still, AVR, I'm not seeing any. And so I'm like, well, is this a junctional rhythm? Let's take a look at the rate. So maybe I'll find two narrow complex QRSs that are kind of right on a solid line, 300, 150, 100, 75, 60. So maybe 65 beats per minute in between these two QRSs. We know normally that junctional rhythms that occur from the AV junction are, so we'll say junctional. So we know the junctional escape rhythms can occur if, for whatever reason, these signals from the atria don't come down and the junction decides that it needs to fire off and send signal down, right? It's a safety mechanism. And junctional escapes occur usually at 40 to 60 beats per minute. Well, in this case, we have a junctional escape rhythm, right? Or we have a junctional rhythm because I don't see any sinus P waves or any P waves at all. And so because of this junctional rhythm at 65 beats per minute, it's a little faster than that 40 to 60. So we would call this an accelerated junctional rhythm. Okay. So we have an accelerated junctional rhythm. And so now we can't really evaluate what the AV node is doing in that sense, right? We can look for retrograde P waves, right? But we don't have a PR interval because we don't have any P waves. So let's look for retrograde P waves. So you can actually look, sometimes junctional beats will not only send signal down, but they'll send signal up. You can get retrograde P waves that are kind of sitting right here on that ST segment. I like to look in leads 2, 3, and AVF for those, but I don't see any. So I don't see any retrograde P waves. Okay. Let's take a look at the morphology of that QRS complex. We said it was a narrow complex rhythm, right? If I measure the duration, you can see it is less than 3 small boxes. My QRS, less than 120 milliseconds. My QRS axis is upright in lead 1, but it's down going in AVF. So I know it's going away from AVF, so it's going up and to the left. And because it's up in lead 2 as well, tells me it's going even away from lead 2, right? So here's lead 2. So it's going somewhere in this region, right? Because AVL would be perpendicular. So it's going somewhere in this region. So that's left axis deviation. So my next goal is to explain that left axis deviation, and I look for something maybe like left ventricular hypertrophy. I don't see that. But I look and I see I've got this left anterior fascicular block, right, as I have this, what I would call this little r, big S in lead 3, so little r, big S in lead 3, and in lead 1 I have this little q, big R, right? Little q, big R. And in the setting of left axis deviation, with that narrow complex morphology, we have a left anterior fascicular block. The anatomy to the left anterior fascicle being blocked is pretty complex, and so I'll actually, if I were you, go head over to my lecture curriculum, and you can see towards the end I've got a lecture on left anterior fascicular block, so it'll really be helpful. So we've got a left anterior fascicular block. Now let's take a look at our R wave progression. You can see I've got this little teeny itty bitty R wave in V1. You can see it, it's right there. It's so small. You can see the R wave grows, a little bit late transition, but it's about almost transition in V4 to V5, V6, so just slightly late transition. Might be because of that left anterior fascicular block. And then, last thing we're going to do is we're going to look at our QT interval. And so my QT interval, I'll take two QRS complexes. I'll measure midway point. And I figure out that there is my T wave that ends by the midway point, so that's reassuring. Next, I'm going to look for pathological Q waves, which I don't see any. That tells me if there's any previous myocardial infarctions. And then I'm going to look for any ST or T wave changes, like ST elevations or depressions, or other T wave inversions. And you might say, well, is that ST elevation in V1? Well, if you look, it's so slight, maybe half a millimeter, that it's not enough to call anything that it would be like contiguous in any sense. So no ST or T wave changes that are really concerning here. And so now we need to turn our attention to these early beats that we said in red. And so we said early beats are either 1, premature atrial contractions, 2, premature junctional contractions, and 3, premature ventricular contractions, right? These are wide, right? So these are wide complex rhythms. And so when they're wide, when they're greater than 120 milliseconds in duration, we think, is this a PAC with aberrancy, where we know that sometimes premature atrial contractions can be conducted with a functional bundle branch block, or is it a PVC? And so I look in front of it, right? I look at the T wave in front of it, right? And I compare the T wave, compare that T wave to the previous T wave, and I make sure there's no atrial activity in front of it. And you can do it up here, it's the same beat, and I don't see any. So these are all premature ventricular contractions occurring every third beat. And so you could actually say that this is, oops, should have been a V, a ventricular trigeminy, meaning that we have a premature ventricular contraction every third beat. And so let's put this all together, and what do we have? We have a accelerated junctional rhythm that's occurring at a rate of 65 beats per minute. We've got left axis deviation with a left anterior fascicular block and PVCs that are occurring in a pattern of ventricular trigeminy. So I hope this video helps you kind of work through this rhythm. It's a fun one. Big thing to think about is, why is this person's sinus node not beating, right? And so I don't see retrograde P waves that would be stunning the sinus node in this case. So what is their history, right? Does this person have sick sinus syndrome, sinus arrest? All the questions you need to be asking yourself. So hope this helps, and if you have any questions, put them down in the comments. And thanks so much for watching. See you on the next ECG video. Have a great rest of your day.